MRI plays a vital role in the imaging of ischemic stroke patients. Although CT imaging is performed in majority of acute stroke due to various factors, MRI is more sensitive for ischemic stroke. When you examine an MRI for ischemic stroke, there are few essential sequences to look at. These include diffusion-weighted imaging or DWI, ATC, FLAIR, and susceptibility-sensitive sequences. Other sequences may be performed as well, such as T1 and T2. The best sequence on MRI to pick up early ischemic change is diffusion-weighted imaging, as changes seen on FLAIR, T2, or T1 are subtle and even not apparent in the first few hours after onset. To keep this video short and simple, we are not going to dive into any MRI physics and focus on the main sequences to look at. It is, however, helpful to understand that DWI measures the Brownian motion of water molecules within a specific voxel. When the brain tissue experiences hypoxia, it causes depletion of ATP, and as many of you know, the sodium-potassium pump consumes significant energy. So with limited energy, the sodium-potassium pump fails and the cells fail to excrete sodium. This may lead to a sodium buildup within the cell and the consequential shift of extracellular water to the intercellular space. Motion of water within the intercellular space is more restricted than in the extracellular space, mainly due to cell membranes. This restriction will show as a hyperintense signal on DWI. So let's look at a case to demonstrate. Here we have a patient presenting with dysarthria and ataxia roughly 1 day after onset. Based on this presentation alone, we might expect a posterior circulation stroke. As with most cases, this patient first goes on CT. On the non-enhanced CT, we see a well-demarcated loss of brain tissue in the left cerebellum, which could be from a previous infarction. But this is much older than 24 hours. Otherwise, we don't really see any acute changes. A few hours later, the patient goes for MRI. The easiest sequence here to start with, as I mentioned before, is the DWI. From the B0 sequence, we scroll straight to the B1000. Here we can see a hyperintense signal in the left pons. Although these changes are easily appreciated on the DWI, we need to make sure to check if this hyperintensity is really a true restriction or not. Diffusion-weighted imaging sequence is in fact a T2-based sequence. So a high T2 signal can also show as a DWI hyperintensity, the so-called T2 shine-through. In order to differentiate true restriction from a T2 shine-through, you look at the ATC sequence, the apparent diffusion coefficient. If there is a hypointense area on the ATC which matches the DWI hyperintensity, such as in this case, it means that this is a true diffusion restriction. Another useful sequence is the fluid attenuated inversion recovery, or FLAIR. This sequence is a T2-based sequence with a long inversion time. This sequence is useful for many reasons, but one important use for acute ischemic stroke is to help estimate the time of onset, for example in wake-up strokes. This can be done with the so-called DWI FLAIR mismatch. It can be quite variable between patients when changes are seen on FLAIR in acute ischemic stroke. However, almost every stroke patient will have FLAIR changes after 6 hours from onset. This means that the patient with signal changes on DWI but no FLAIR change has a mismatch, and we can therefore assume the onset of symptoms within the last 6 hours. In our case, the DWI and FLAIR changes match, as was expected with onset of symptoms 24 hours prior to imaging. Intra-arterial FLAIR hyperintensity is also helpful, as this is an early sign of a major vessel occlusion or a limited flow. Hyperintensity on T2 is usually seen 12 to 24 hours after onset. So for a hyperacute case, this sequence is somewhat less useful. In our case, we have a T2 signal hyperintensity matching the DWI. T1-weighted imaging is also not crucial for acute ischemic stroke. One last sequence to mention is the susceptibility-sensitive sequences, or SWE. These sequences can detect blood product. It will appear as a dark, blooming artifact, which can be seen with hemorrhagic blood products. As previously mentioned, the majority of patients, however, will go for a non-enhanced CT, which is robust for diagnosis of intracranial hemorrhage. So MRI is somewhat less utilized for intracranial hemorrhage in the acute setting.